And let me talk about the arachnoid membrane and cisterns and its importance in especially meningioma surgery. The beginning of the lecture will be the same as the last time when I gave similar lecture. There are two main topics and two main spaces where we operate. It's in vasculars, read aneurysms. In this case, we are in subarachnoid space and we cut the arachnoid and we open the cisterns. Just the opposite is true for meningiomas, which are growing extra-arachnoid, mostly the smaller ones. So we lift the arachnoid and we preserve the membrane. That's the main difference between the two neurosurgical big fields. Here is the ophthalmic aneurysm, and you see that all the arachnoid of carotid cistern is cut away. The aneurysm is dissected free from any arachnoid bands. Here is the optic nerve, which is again liberated, and you are in the space which is completely different from the one we are in when doing meningiomas and other skull base. Going through subarachnoid space, you can go from one end of the vasculature to the other, from ACOM to basilar artery, whatever you name it. This is carotid, this is middle cerebral. All the three can be dissected free, and you see that from the approach, you can clip 5 aneurysms from one M1 to the opposite side, M1 to. Meningiomas are completely different. Here is a tuberculum cellae meningioma, and you see that in this case we lift the arachnoid chiasmatic cistern, and this is after the surgery, and the arachnoid bands are preserved, since these represent the border line which we do not cross unless necessary. This is the video just to show you how I lift the arachnoid. Okay, it's at the bottom of the image, and you see that the arachnoid is lifted, it's not cut through, because it's really the natural border, the natural frontier of the meningioma. And as long as the meningioma has a smooth and shiny surface, it's not the tumor, it is the arachnoid. The normal appearance of meningioma is rough and grayish. You have 3 kinds of growths, as Yashargil has postulated, and that's important for all surgeries. We have this non-adhesive, which is this region of the large parasagittal tumor. Then it's adherent, which is over here, where the arachnoid is already affected, but not the cortex itself. And then it's adhesive, where definitely the cortex will suffer our maneuvers. And this is especially true for skull-based meningiomas, about which I will be talking mostly, because we are not in the complexities. What's important and is depicted on this image is there are 2 cribriform plate meningiomas, identical in volume, identical in all respects, apart from first the edema. Edema in this case is unilateral, in this case bilateral. In this case, the anterior cerebral arteries are in the midline, and in this patient, they are shifted to the opposite side of the edema. What does it mean? And it's very easy to comprehend. In this case, the left front lobe is covered by 3 layers of arachnoid. The arachnoid is dragged by the anterior cerebral arteries. In this case, both frontal lobes are covered by 1 single layer of arachnoid only. That means that it's much more endangered the both front lobes, and in this case, where the left side is protected, you most likely will be able to preserve the first nerve, the smell for the patient, which is the case of this patient. It's by the end of the surgery, the tumor is already resected. This is a little remnant at the origin. And what we see in the background over here, it's the opposite side olfactory nerve, which was preserved along with its function. And you see the bed of the tumor is above the nerve, but still the nerve may be preserved because it's still covered by its arachnoid. The anatomy of arachnoid membrane is not really well covered in the literature. These are the Roton's images. which probably are one of the two best, where you see all the systems. They are very well defined and very well described, very exhaustively. Still, what we see as the firm borders, it's not always true. Usually, it's not really that through the outer layer of the arachnoid. That's really the firm border, impenetrable. But the divisions between the respective systems is not that clear and not that clear cut. The only structure within the basal systems is the Lillian-Quist membrane, which usually serves as a division between the supratemporal and infratemporal. You see it very well here. This is already Kurt, who published excellent works on anatomy of cisterns. It was done with the endoscope, and the images are excellent. And if you take a look on many of them, you need to read the descriptions carefully because it's not that easy to understand. But the descriptions are fine. And just check here that it's really not always the wall. It's like bands and strands. I will show it to you a little later. These are our dissections. These are from Tour. Then thanks to COVID, we had to start our own lab. So here is the carotid cistern opened, and here is the pontine cistern where the basilar tree. And you see that the only firm structure here is the Lillian-Quist membrane, which separates the two compartments. This is what I was talking about. It's, the arachnoid is more like a scaffold or something like which holds nerves and vessels in its place. And you see that those are strands, fibers, trabecus. It's not really the wall. Here, the ambient cistern, crural cistern, carotid cistern. This is the pontine cistern. And still, there are not really well-defined walls between the two. And of course, CSF runs freely in the respective system. This is obviously the third nerve. And actually, what we are talking about is a very tiny space. The diameter of the circle is set 5 millimeters. The tennis ball has set 8 millimeters. From acom to the vertebral junction, it's some 30 millimeters. So we are really talking very, very compressed space with the most difficult anatomy in the human body. And this is just interested how it is with Almeft is great group 1 and group 2 and 3 meningiomas. And really there is the lack of arachnoid membrane between the distal ring and intracranial space. We are looking from below, don't forget that. And this is exactly the dangerous part of the internal carotid artery in anterior clinoid meningioma. The same is seen here. There is really a space between the carotid, between the subarachnoid space, which is over here underneath, and the carotid rings, which actually can be cut, as seen here, but it's not really practical. So on the anterior and middle part of the carotid, you can get easily beyond the distal ring. This is not as easy in the lateral portion and in the posterior portion. Another example of these dissections and how the arachnoid behaves. This is the fifth nerve, this is the sixth nerve in its cisternal part and in Dorellos canal. And you see that the arachnoid of the cerebropontine cistern is turning like medially when it passes the fifth nerve. So should, here used to be the petrous bone. So should the tumor start here in the superior petrosal sinus, posterior to the nerve, it pushes the arachnoid in front of itself, and the brainstem, which is over here, is covered again by more arachnoid layers. Unlike in this case, if the tumor starts growing more medially, anterior to the fifth nerve, then there is only one layer of arachnoid, and of course, then the dissection from the brainstem is much, much more difficult. Arachnoid systems are important in planning the approach with advanced knowledge of systems and expected layers. What's very important is the tumor origin definition. It's on T2 images. T1 images is Gado. It's for radiologists, not for neurosurgeons. For neurosurgeons, it's T2, where you quite frequently see the exact origin of the tumor. Defining in which system we are doing our job. It's throughout the surgery, and once structures are there, And what's important, whenever possible, stay within one system. Don't cross the border to the other system. Don't leave in anterior clinoid meningioma the carotid system. Stay within one system if possible, not always. And respect the barrier. In this case, this is the Lilienquist membrane as seen from posterior. This is the posterior clinoid process, superior cerebral artery, and the third nerve. So this is where we are usually coming from, posterior or anterior, it doesn't really matter. So aneurysm surgery is about the arachnoid. The arachnoid, do not tear the arachnoid. It's like in this ophthalmic aneurysm, where the yes, it will. You see that the arachnoid, the optic nerve is split on the surface of aneurysm, and the border between the nerve and the arachnoid and the aneurysm is nearly invisible. So if you dissect the arachnoid well from the optic nerve, then you get the aneurysm, then you can close it, and you see what was the pressure on the aneurysm. Let's go forward. This is after the surgery, after the clipping, and after the liberating of the optic nerve. And you see the preserved arachnoid on the surface of the optic nerve, well-preserved vasculature, and actually the patient's vision improved the day after surgery, even despite the very badly looking optic nerve at the beginning of surgery. It was completely split. Again, meningioma surgery, it's again about the arachnoid. Do not cut it unless necessary, just lift it. This is the case I was talking about, the petroclival on Petro's apex meningiomas, posterior to the fifth nerve, may look same as those which arise from clival or posterior clinoid region. But these are much easier because there are much more arachnoid layers, at least two, on the medial and anterior border of the tumor, unlike in this case where there is one arachnoid layer only. So let's go through several cases. Simple CP angle meningioma, you never ever enter the basal cisterns. This is the wall of cerebropontine cister, which is hooked to the Dendis vein, and it's never penetrated, and thus the structures are not endangered. This is the fifth nerve, obviously. This is the other case. This is Petro's bone or superior petrosal sinus meningioma, but the one which starts growing posterior to the fifth nerves. And you see that after resection, you have prepontine cistern along with the superior cerebral artery and cerebral pontine cistern, and all the arachnoid walls are well preserved, undamaged. Even the division between the two cisterns is left untouched. And this is how the surgery should look. This is the more medially located tumor, and you get into the cerebropontine cistern, even into pontine cistern. This is the sixth nerve, and there are only strands of arachnoid which really is preserved, and the dissection against the brainstem was much more difficult than in the previous case. Ambient cistern meningioma, and you see that after the surgery, we were only in the ambient cistern, nowhere else. This is the wall of the cerebropontine cistern, which is preserved and C-junction meningioma, again the same cerebromedullary cistern at the end of the surgery. This is the 11th nerve, this is the 12th nerve, which was doubled in this case, which is two hypoglossal canals. Never ever seen anything like that. Pablo, you can have some remark on that. And again, the fracture is preserved, and the whole surgery was done only within the cerebromedullary cistern. No other cistern was entered. Tuberculum filae meningioma, the same thing at the end. You see the chiasmatic cistern wall, which is preserved against the brain and against the optic nerve, thus nothing should be harmed. Small anterior clinoid meningioma, which is causing vision deterioration, of course, and at the end, this is the carotid wall of the carotid cistern, wall of the chiasmatic cistern, and only the optic nerve is dissected, free tumor is resected. Another anterior clinoid meningioma with completely engulfed carotid artery. The triangle between the retroclinoid ligaments is full. And this is throughout the surgery. You see that here is the tumor, which is partly resected now underneath the optic nerves, and the wall of the chiasmatic cistern is preserved, and the same in the back. Now we are laterally and behind the tumor, which used to be here, and this is the Lillienquist membrane, which is preserved and never entered. Here you see the precum and anterior choroidal, which are still covered by some arachnoid, but since they were within the tumor, they are nearly dissected. And this is at the end. At the end, I dissect the arachnoid rather frequently just to clean the cistern. So here is optic, carotid, basilar bifurcation, posterior clinoid, anterior, and the third nerve. And you never leave the space of carotid cistern resecting such a tumor. So this is what Imad Kanan is always saying, that arachnoid is a friend, and arachnoid belongs to the patient, which means preserve it, do not cross it, do not cut it unless necessary. Do I have a minute or not? Or am I done with time?
No, you are in time.
I am on time. All right. So let me just go through one of the
4 minutes. 4 minutes more.
It's within a minute. Phenopetroclival meningioma, and there are several cisterns which needs to be crossed. There are 4 stages: resecting the CP angle portion, then cutting the tentorium, subtemporal portion of the tumor, and the prepontine and interpeduncular part. So what you start with is the 7th ICA and 5th, which is the cerebropontine angle, the cerebropontine cistern. Then going deeper, you get 5th and 6th. Again, we are still in the cerebropontine cistern. Here is the 4th passing across the surgical field. So here we are in the ambient cistern, and we are going forward to the interpeduncular cistern. This is the opposite side, P2. Here are the remnants of the arachnoid on the opposite side, tractus and pituitary stalk, posterior clinoid. The same on ipsilateral side, posterior clinoid, posterior cerebral artery, the third nerve, and the superior cerebral artery running towards us. This is the basilar artery, and you see again that the Lillienquist membrane is the border which the tumor very hardly crosses. So despite the fact that we were throughout the surgery in 4 cisterns, we were really stopped by this arachnoid membrane. This is the whole approach, supracerebral infratentorial, the tentorium, and this is the post-op image. We never enter the cavernous sinus, vincophore. I don't think it's reasonable when we have gamma knife or cyber knife, so it's better not to cause diplopia. That's it. Thank you very much for your attention.